Welcome everybody. I hope you're all familiar with the fact that this presentation will be in English because we have a very special guest with us today. So I got to meet Jeanne Lenzer last summer during the Data Harvest Conference, which also. And as a former medical student, I was absolutely thrilled by Jeanne's knowledge and expertise. So she's an absolute icon in the field. So we're very happy to have you here today, Jeanne. Jeanne wrote for the New York Times, Washington Post, The Atlantic, Medical Journal, and so forth. So today, Jeanne is going to learn us all about medical trickery and illusions. Has a lot of expertise in the field of hidden ties between money and medicine, and she has shown how profiteers distort. And I'm sure that this session will be very useful to all of us, especially in these times of pandemic. Before I give the floor to you, one more thing about the question. So I think it would be very nice if we all come up with some nice questions to make an eye on it. And we leave the last 10 minutes for questions and discussion. But of course, if there's anything that needs immediate clarification, short intervention, that's all fine. But we leave the major questions for the end. So please write them down if you hear something interesting. And yeah, with that said, I think, Jeanne, the floor is yours.
Great, thanks so much, much appreciated. So let me get my slides going here. Same problem, it's not sharing. Please tell me I don't have to go out and back in again.
All right, I can do the sharing for you as well.
Great, that would be wonderful, thank you. Okay, and I'll
and then
just
we
say
should
next
figure
slide.
Just a sign when I need to, yes. Let me see if it works for me.
Yeah, I'll just say next slide if that's okay.
Wait a second.
So while you're working on that, I'm just going to say that on the first slide, well, actually it's the second slide, you're going to see my identification. So if anyone wants to contact me, you can do that. I'll show that slide again at the end. But the slide after that will show an image of medical illusions. And there we go. Great. Okay.
Wait a second.
So that's the first. Okay.
See if this works. Ooh, it's tricky.
Oh, it's filling in there.
Okay,
we go.
How does this look for you?
Beautiful. Looks beautiful. Good. I can see it. Super.
Yes.
And there's my ID that I said, you know, I'll show again.
So let's try this way.
Yeah. So next slide. So medical illusions are a lot like optical illusions. And most of you are familiar with that picture on the left that can either look like I don't know if you say vase or vase, or it can look like two people looking at each other. And these illusions can be very compelling. And I want to start this by telling a story. And it's a story of a very compelling medical illusion. And if anybody wants to read more about it, I wrote about this in the magazines Smithsonian and Undark. Can you hear me okay? Is that an issue?
Kun je mijn camera uitzetten of niet?
Okay. So this story starts with Keiko Yamaguchi. And she developed diarrhea. And then just a few weeks later, her toes went numb. And shortly after that, the numbness crept up her legs to her hips. And then her vision.
Want ik kan nu dus niet de chat in de gaten houden.
We can hear you. Colin, are we okay? Shall I continue?
No, sorry, just continue.
Oh, okay, all righty. So
yeah, sure.
So by these symptoms all started in early 1967. By the end of 1968, Keiko Yamaguchi, just 22 years old, was blind and paralyzed from the waist down. And many other people around the globe, but especially in Japan, also came down with this disease. that came to be known as SMON, or subacute myelooptic neuropathy. Somewhere around 900 people died, and the outbreak occurred in clusters. Family members developed it, doctors and nurses who treated the patients developed it, and it was pretty terrifying. And it occurred shortly after the polio epidemic. And people from around the world, doctors and researchers from around the world, got together trying to figure out the cause. And they thought, you know, since polio was caused by a virus and it also caused paralysis, it seemed likely that this was also due to a virus. And people got excited when the first researcher found echovirus in some of the SMON patients. But then other researchers couldn't replicate that finding, and then they became more excited when they found Coxsackie herpes virus. Herpes was compelling because it does affect the nervous system. But all of those findings were shot down when they couldn't be replicated. So they started looking at other things. Was there something in the water that was causing this? And they didn't find any pathogens in the water. And then they wondered about pesticides. Turned out that farmers who would have the greatest exposure to pesticides actually had lower rates of SMON. So this epidemic went on for 15 years before the cause was found. And eventually what happened is they realized that it was caused by an antibiotic, cleoquinol. And what happened was, it turns out that people, particularly in Japan, were likely to take this antibiotic as a preventive or a treatment for GI or gastric upset. So if they developed diarrhea or vomiting or just vague stomach upset, they would take cleoquinol. But when this epidemic broke out, people were terrified and they didn't know what the cause was, and assuming it was a virus, and they saw that people who developed this disease went blind and became paralyzed, they would take this medicine to prevent it because they saw that it started with diarrhea. So if you'll show the next slide. Oh, by the way, when they stopped the cleoquinol, it brought the epidemic to a complete halt. So this is something I call cure as cause. And cure as cause is a curious problem in that what looks like a complication of a disease can actually be a complication of the treatment. And I give 3 examples here. And I want to mention why cure as cause is so common, and that this is not a rare outlier. It's a very sort of impressive story because it looks so infectious. You know, here it is, family members coming down with it, doctors and nurses coming down with it. It certainly looked infectious, and that was a very natural illusion. And I'm going to talk about both natural illusions as well as the ways that industry, or that is medical device makers and drug makers, exploit this illusion to their benefit. So when a drug or device causes this phenomenon, cure as cause, it's natural in that virtually every time we interfere with the body system with a drug or device, we're perturbing it, and it's very easy to overshoot that. And so these examples exist within virtually every specialty, whether it's OBGYN or dermatology or gastroenterology or cardiology. And I'm going to give just 3 examples of how this happens. So there was a VNS device, that's a vagus nerve stimulator, that they would implant in seizure patients to treat seizures. But it turns out the device actually caused seizures. Now it's still on the market. And it's very tricky. I don't have the time to go into how they managed to pull this off and get it on the market, even though it was causing seizures and deaths that were very concerning. But when people had seizures, including the patients themselves, they thought it was their underlying disease causing the problem, not the VNS device. And yet later, it was clearly able to demonstrate that the device did cause seizures. The second example is there's a whole class of drugs that were widely used to prevent a potentially fatal heart rhythm. And it was very impressive because it would reduce those heartbeats. And yet, when the patient did develop them, they were 3.4 times as likely to die as the patients who were given placebo. So here you have an at-risk group of people. You divide them in half. That's the CAST trial or study. You give half of them the drug and half of them placebo. And the patients given the drug were 3.4 times more likely to die. That illusion, that went on for, I think it was like at least 10 years that we gave those drugs. I prescribed them myself, thinking that we were saving lives. We saw some of those bad rhythms disappear, but when they did occur, they were deadly. So again, the cure being the cause of what we thought was underlying disease. And the same thing was, it was SSRI antidepressants. We give those drugs thinking they're going to reduce someone's depression and likelihood of committing suicide, and yet there's studies showing that they actually double the suicide rate. Now, there are other things that, if you go to the next slide, that contribute to our inability to see the truth about drugs and devices, and that exploit these illusions. So see no evil, report no evil. The Agency for Healthcare Research and Quality has found that fewer than 1% of drug and vaccine adverse events are reported. And some of that is because of these illusions. You see suicide in a patient, you say, well, no, it's not the antidepressant. You see a funny heart rhythm and somebody dies. You ascribe it to their underlying condition and you don't report it as an adverse event. Some of it is we see the problems, we know it's from the drug or device, but we just don't report them. So the problem is, if you're going to decide what's going on, is this problem, was this death due to the VNS device or something else? Next slide. You want to know who's going to decide about this. And according to the FDA, you only have to report a side effect if the drug or device caused or contributed to the event. So next slide. Who do you think gets to decide? Could you go to the next slide, please? So who do you think gets to decide? Is it the patient, patient's doctor, an independent panel of experts, the FDA itself? Yeah, you've probably guessed by now the answer is the manufacturer that has billions of dollars riding on whether their drug, their vaccine, their device is causing a deadly effect. So I want to mention that when Lilly was testifying and in FDA hearings that Prozac, an antidepressant, didn't cause suicidality, they had already conducted a randomized controlled trial of patients who were given placebo. It was of all the patients they knew of who had been given placebo versus Prozac, depressed patients. And what they found was it doubled suicidality. Now they knew that, and they had that study in their hands at the time that they were testifying in FDA session, that it was the underlying depression that caused suicidality, not the drug. Now, of course, in any one individual, it's really impossible to tell whether a drug or device is causing the problem because, yes, people committed suicide long before Prozac or and other antidepressants. But at the same time, the big question is that drug or device increasing or decreasing the problem? And that we can only understand with randomized controlled trials or other forms of good studies. So another form of illusion comes with disease creep. Next slide, please. Can you go to the next slide, please? Good. So disease creep, that's when risk factors for a disease are treated as if they are the disease itself, or we broaden the value. So for example, with hypertension or high blood pressure, that's been an expanding diagnosis for years. Disease creep. Instead of saying that 160 systolic defines hypertension, they dropped it to 140, then they dropped it to 120. And so you're getting many, many, many more people defined as having a disease. This is true of elevated cholesterol. High cholesterol isn't a disease in itself. It's a risk factor for heart attacks and strokes. And the same thing with ductal carcinoma in situ. That's just in the mammary ducts that that are slightly abnormal, but they haven't invaded. They're not a cancer. They are simply a risk factor for cancer. And in fact, only 1 to 2% of women diagnosed with DCIS will die of breast cancer in 10 years. That means that 98 to 99% of women with DCIS won't die of breast cancer or won't even develop. All of those women in the United States are subjected to surgeries, chemotherapy, and deadly effects from surgery, and like I say, chemotherapy, which can be deadly in its own right. So when you expand a diagnosis, you expand the problem of hurting people who are at very low risk to start with, as opposed to treating the people who've already developed some symptoms. This seems counterintuitive. It seems like you would want to treat things early to save lives, but it turns out that what you're doing when most people are going to survive it anyway, you can actually cause more harm than good. And that's where actual hard numbers come in to play. It's a very important effect. I'm going to talk about that a little bit more later. So presence of COVID in the world is a risk factor. And I'm going to get into that a little bit later. It's a risk factor. It is not a disease in itself. And yet there's the potential that we will be treating all people as if they have the disease. That was certainly true when people started saying, let's take hydroxychloroquine to prevent it. One could cause enormous harm that way. So there's two illusions, next slide please, thank you, of disease creep, and that's the illusion of benefit and the illusion of safety. And if you'll go to the next slide, I want to tell a story about of disease creep. Yes, so here you see, I don't know if I use my pointer, does my pointer work to show? I'll have to describe what I'm talking about. Okay, so the blue square on the left, think of that as all people who are diagnosed with a heart attack. And you can see the black circle with deaths. Those are the people who die of heart attacks. That's what went on prior to the 1970s. 35% of people with heart attacks died. And Eugene Braunwald, the father of cardiology, was credited with dramatic reduction in heart attack deaths because he promoted this drug, this clot buster called TPA for heart attacks. So the mortality rate with heart attacks dropped from, on the left, at 35% down to 5%. You can see the death circle is very small there. It's a 35 to 5% mortality reduction. It seems very dramatic, seems wonderful, seems like everybody should be getting TPA automatically if they get diagnosed with a heart attack. But let's see what really happened. Next slide, please. You go to the, yeah. So what actually happened is, now look at those two black circles. They're actually almost identical. And what actually, back in the 1970s, a new test was developed that could, and these tests have improved over time, so that what these blood tests would do was they would detect tinier and tinier bits of heart that had been damaged, little bits of enzymes that had leaked out of damaged heart cells. Now, the picture on the left where the black circle is big shows what happened then was diagnosed with heart attacks had to have severe chest pain, and they would have changes on their EKG. Those people were indeed at high risk of dying. Over a third of them die. But now on the right, when you have a 5% risk of dying, it's not that the black circle got smaller. It's not that there was a reduced number of deaths. It's that now you are defining massive numbers of people with heart attacks, people who may have not even had a single symptom of a heart attack, but a blood test detected little bits of enzymes leaking out of damaged heart cells. Those people were far less likely to die. And that accounted for a huge proportion of the drop in death rate. In fact, when they looked at the studies, what happened was, it turns out that this clotbuster drug that was promoted as causing this grand effect, it accounted for a 2% absolute risk reduction, the same as giving a single aspirin. And giving an aspirin and the drug together dropped the death rate, dropped deaths by 4%. So every time you hear someone say a rate, you have to ask, well, what's the total number of deaths? What's the absolute number of deaths? And in fact, there's a graph which I don't have here, but when you look at prostate cancer screening, you hear, oh, people are much less likely to die if they get their PSA test done. But when you look at the absolute mortality, the rate never budged from around 30,000 in the US. Next slide, please. So on to COVID. The first treatment out of the starting gate was hydroxychloroquine. And Trump, and I would never, ever quote Trump on anything, but in this instance, what's important is that what he said when he kept urging people to take hydroxychloroquine is, what do you have to lose? Well, the problem is a lot of doctors parroted that same thing, and around the world, large numbers of doctors were prescribing hydroxychloroquine. In fact, the overwhelming majority of doctors had prescribed it in a number of countries. I think it was something like 30%. Maybe I have that in a slide, I don't know. But yes, I do. Next slide. So it turns out that 1 in 10 doctors in the UK prescribed it, 4 in 10 in the US, 5 in 10 Chinese doctors, and 8 in 10 Italian doctors were prescribing it. Now I want to move on to this slide, which is Didier Raoul. So he's the one who sort of kicked off the whole craze. And he did this study where he treated 26 patients with hydroxychloroquine, and he compared them to 16 control patients who got all the usual care, but they just didn't get hydroxychloroquine. And after 6 days, which was the end point that he stated, let's give them 6 days to get rid of this virus, 70% he treated with hydroxychloroquine had cleared the virus. They were negative, and only 12% of the control group had cleared it. It sounds really wonderful, and in fact, he reported it as wonderful. He said the reports were positive and of great importance. For more on that, you can see my article in the BMJ. Next slide. But here's what actually happened, and this is where we get into the issue of surrogate markers. And surrogate markers are an endpoint or an indicator, such as a laboratory result associated with the disease being treated. So, for example, a blood sugar test known as hemoglobin A1C is a surrogate marker for diabetes. And blood pressure is used as a surrogate marker to prevent heart attacks or strokes. I mean, blood pressure, again, in and of itself is not a disease, it's a risk factor. However, you can lower someone's blood sugar or blood pressure and still kill the patient. A surrogate marker can only measure benefit. That's the target you're looking at. And it doesn't account for harms. And it also, as we will see with Didier Raoul's study, can be seriously wrong. So we're going to return to Raoul and his study in the next slide. And in this slide, we'll see what happened. What's really important, anytime you see reporting on a surrogate marker, is to look at what's the clinical outcome versus a number or a laboratory test. And here's what happened in Didier Raoul's study. You can see in the treatment group, below that, the patients who got hydroxychloroquine, 2 patients had a withdrawal, and often that's because of side effects. 3 patients were transferred to ICU because they got worse, and 1 patient died. In the control group, there were no withdrawals, no ICU transfers, and no deaths. All of the bad outcomes, and these were seriously bad outcomes, occurred in the treatment group. And yet he got to announce this as a positive trial, and people all wanted to take hydroxychloroquine. Doctors in the US were hoarding these drugs so much for themselves and their families that, along with prescribing them to patients, the pharmacies were reporting they didn't have enough of the drug to give to people who were truly at risk of dying and needed the drug with lupus and malaria. So next slide, please. By the way, he got to, I'm sorry, can you go back to the previous slide? So, by the way, the reason he got away with failing to report those 6 deaths, I mean, they were reported in the small print, nobody saw it, was that they didn't make it to 6 days. And that sounds fair enough. Well, you want to give them enough time to get better, did they clear the virus from their nose at 6 days? But again, that's a surrogate marker. We don't care if you cleared the virus from your nose or your blood. We want to know, does it prevent you from dying? And this is a problem with vaccines when we look at antibody tests. Well, with flu virus, it turns out you can get antibodies in patients, but elderly patients with flu continued to die because they were frail and elderly. So next slide, please. There was an unnoticed problem in Raoul's study too, and that is that the one patient who died in the treatment arm had already cleared COVID at the time of his death. 24 hours before he died, they did a test and he had cleared it. So the question is, maybe was the test a false negative, or did he die of the cardiac effect from the drug? Next slide, please. So there's observational trials, and all of us really want to know is, what are the aspects or the components of lockdown that work? Do masks work out in public? Do they work in certain environments? Is closing schools necessary? You know, all these different components of lockdown, travel, quarantine. It's very tempting to try to compare one country to another, one state to another, even comparing one county right next to another county. Seems desirable, but it's fraught, and we're going to get wrong answers because we have to know what's the age of the population, how many people are institutionalized or in nursing homes, what's the wealth gap of the country, baseline health, how many people are obese, what's the weather at the time of testing, many more questions that are going to make differences between seemingly similar populations. So for example, you might have one county in an area right next to another where people seem pretty much the same, but maybe that one county has a prison and the other one doesn't. So these are problems with observational trials that we have to be really careful about. And there are some ways that we can try to get answers to this. And I think probably all of you are aware by now of the Danish mask study that had so much trouble getting published. But these kinds of randomized controlled trials are really important. But even randomized controlled trials, if you'll go to the next slide, which, as you know from the top of the pyramid, as Serena has shown in her slides, well, at the top, and then systematic reviews, they can be gamed, and they're gamed all the time. And this is where industry really comes in exploiting things. So here are just some of the many, many ways that we can get wrong answers from randomized controlled trials. And I'm just going to discuss a couple of them. So we already talked about surrogate endpoints with Raoul's study. And I mentioned them with diabetes when I said, you know, you can lower the blood sugar with Avandia, but gee whiz, it killed people with congestive heart failure. I want to talk about disease-specific versus all-cause mortality. So let's take lung cancer, for example. So if you have a new treatment that is good for lung cancer or a screening test, you might want to say, how many people die of lung cancer when you do or do not use this particular intervention? That seems like the logical answer. That seems like what you want to know, isn't it? Are they less likely to die of lung cancer? No, it's not what we really want to know. What we really want to know is your treatment or your intervention going to kill more people than it helps? So in many instances, a drug can be deadly, like penicillin, but it helps far more people than it hurts. So it's a game of absolute numbers that have to be carefully pulled apart so we know what the answer is. And the only way to get that answer, for example, with cancer treatments, is to look at all-cause mortality. So with lung cancer, I'm going to tell you about the Mayo Clinic study. Here, what they did is they said, well, heavy smokers are at high risk of getting lung cancer, so let's divide them in half. And half are going to get frequent chest x-rays every 6 months so we can figure out, so we can detect cancer early and save lives. And that was a reasonable idea. So in the 1960s at Mayo Clinic, they started this study. And at the end of the study, what they found was interesting. Yes, there were some fewer lung cancer deaths, but the people in the control arm that didn't get the frequent x-rays were actually slightly less likely to die. Overall, there were more deaths in the treatment group, in the intervention group. So why was that? I don't know that radiation had much to do with it, but we do know this. The finding of incidentalomas is really a problem. Incidentalomas are findings that were not anticipated. They have nothing to do with the diagnosis that you're going after, and they're generally benign. They don't cause a problem. So when they started doing x-rays repeatedly on all these men, they would pick up these tiny little nothings, these little bitzels, and they could be old healed granulomas, something, you know, from an old infection. They could be scars, but the doctors wouldn't know whether it was cancer or not. So what they'd do is they'd start sticking needles in to get biopsies, or they do open surgery because they couldn't get at that area of the lung. And the second you start doing those invasive interventions, you can cause hemorrhage, you can cause infection and deaths. So these invasive interventions harm people who were never going to die of lung cancer in the first place, and it completely balanced out the number of lives that were saved. So we no longer do routine chest x-rays of smokers for that reason. There are many other examples like that. Subgroup analysis, as everybody knows, you know, a subgroup analysis, that's when you only look at a certain portion of your study. So maybe, you know, you have an intervention for disease X, but you only look at it in people who have green eyes and are left-handed. And you ignore all the people who have brown or blue eyes and are right-handed. And once you do that, you can make a hypothesis with that finding if you find that indeed people with brown eyes who are left-handed happen to, you know, do better than other people. But it's a hypothesis and you have to test that. You can't just go in and say this is, you know, true. And yet that's what happened. And by the way, all these studies I'm talking about have been published in the top medical journals. And this particular study that I'm going to mention with subgroup analysis was high-dose steroids for acute spinal cord injury, published in the New England Journal of Medicine. And that triggered, I think it was like it was more than a decade worth of doctors using this drug that many of them suspected was actually killing more people than it helped. And eventually that's exactly what they found. It was. And then guidelines dropped that recommendation to use high-dose steroids, all based on the fact that they had reported a subgroup analysis rather than the full analysis of all the people treated. Straw man comparator, and here's one of the most horrific examples. Pfizer went to Nigeria and treated children with during a deadly outbreak of meningitis. And this is one of the worst examples of medical imperialism. What they did is they use this straw man comparator. And a straw man comparator in medicine means that if you want to show that your drug is beneficial, better than another drug, what you do is you give your drug at the best, highest therapeutic dose, and you give your competitor's drug at a somewhat lower dose. If you want to prove that your drug is safer, you give your drug at a lower dose, and you give the competitor's drug at the highest acceptable dose. So what Pfizer did in Nigeria, kids dying of meningitis, they gave the comparator drug against their new drug. The comparator drug, known to be effective, known to save lives, at 1/3 the recommended dose. That antibiotic, they dared to do that. These kinds of things, unfortunately, are far more frequent than we'd realize. And I'm going to talk about financial conflicts in the few minutes I have left. But first, I just want to briefly mention lead time bias on the next slide. And so here you see a fellow strapped down to a railroad tie, and he's going to die. I mean, he is, that train is bearing down. There's nothing that's going to prevent his death. But on the next slide, what you see, this will explain lead time bias. The train is far away at a distance, and in fact, there's a diversion on the railroad tracks there where the train could go off in a different direction. Now, the difference between the previous slide and this slide is that the person, say we're talking about cancer again, it's detected near the time the person is likely to die. Say 50% of the people are going to die of this certain cancer, and 50% will survive. It's going to happen in a much shorter time frame. But if you start doing these tests where you detect something far earlier, and let's think of PSA screening for prostate cancer. Now you see that you have a test that shows you may or may not even have prostate cancer, but you know it way, way, way in advance. So instead of learning you have prostate cancer 1 year before you're likely to die, you're learning it 13 years. And that is the issue of lead time bias and survival. So in the first instance, where it's nearby, people say, oh, you only survive a year. But now I've got an intervention that'll make you survive 13 years. Well, you're not surviving any longer. You're still going to die at exactly the same time, except that you not only get to worry about it for a longer period of time, but in fact, you may not even die because that train may take the diversionary path and may not even hit you. And again, this raises the question, what are the absolute numbers? Are you hurting more people than you're helping with the intervention? And some interventions, of course, will help, but we have to consider these other problems. So I want to go on to the next slide, disease-specific versus all-cause mortality. Here's just an example of mammography, and this comes from the Harding Risk Center, which is what they do wonderful work. And when I show this slide to women who get mammograms, and by the way, I've never had a screening mammogram in my life, and I'm old. And the reason I haven't is because I've known about this. The same number of women on the left, you see those red circles, will die. Yes, you'll have slightly fewer breast cancer deaths, but the same number of women are going to die with mammography screening. And in fact, now you're going to have a lot more harms, as you can see from the blue and the other colors. So next slide, please. And in fact, I'm going to skip the next slide and the next slide so I can get on to something very important, which is, I do want to talk a little bit about Minglish. You get to that slide? Great. So the word significant, when I talk about Minglish, I'm talking about plain language versus medical speak. And in plain language, if we say something significant, we think of that as meaning it's really important. But in medicine, it has absolutely no relationship to importance. All it means is that statistically, the finding is unlikely to be due to chance. In fact, only 1 in 20 will be due to chance. But remember that 1 in 20 could be pure chance finding, and it really isn't a finding. But a significant finding only means chance. It doesn't mean the finding was important. So for example, with high blood pressure, say you have a drug and it's announced as it had a significant effect on blood pressure. Forget the word significant, number one. Number two, look at the effect size. What was the effect size? So it drops someone's blood pressure from 183 down to 180. Is that clinically significant? Will that reduce the number of heart attacks or strokes? That's what we really want to know. The second word, and, that has to do with combination endpoints. So this drug that was used for stroke, Clotbuster, was widely announced as saving lives, even though no study ever showed that it saved lives. And in fact, several studies had to be stopped because it killed people. How did they get away with announcing that it saves lives? They used combination endpoints where you combine other findings, laboratory findings, hospitalizations, whatever, with an important endpoint. And if you get a result, well, you didn't hospitalize as many people, or gee whiz, these certain numbers on their lab tests were better, you can actually still have more deaths and announce it combining those endpoints. That's misleading because in plain language, if I say I went swimming and I went to the store, it means I did both things. I'd be lying if I didn't do both. But in medicine, no such thing. A combination endpoint only means that the single number that comes out of that endpoint is actually the same or better. So the word benefit, if I say I benefit from something, say I tell you that you should go to my bank because it's really beneficial, I've benefited from it, it means that I have experience to know that the fees that they charge are less than any interest I got. What we mean is net benefit. When we talk in plain language, that's what we mean. I'd be lying to you if I said, I benefited because I got, $5 extra on interest, but they charged me $50 on fees. And yet in medicine, that can happen because you're reporting multiple endpoints, or you're reporting a benefit without talking about adverse events. And that happens too, because say you give a drug that causes liver failure, but the drug you're giving is to save their life from a certain cardiac event. Well, that's what people want to know about, is the cardiac event. So you say, I reduced cardiac events. Well, how do you measure that against the number of people who died from liver failure? So some of it's natural, but beware. The word may, whenever you hear the word may, it means think may or may not. Always translate it. Right. And then to the financial stuff, and I'll skip over this quickly because I see I'm running out of time. We want to get to any questions. Financial versus personal conflicts. This is really important. When the issue of financial conflicts of interest is raised, some people, usually those who want to dismiss concerns about financial conflicts, say, well, personal conflicts of interest can be as powerful as financial conflicts. And we all know on a personal level that can be true. We get wedded to our own ideas. We may want to prove something badly. We may have trouble letting go of a certain idea, but that's not what's important. What's important are, next slide, the really significant differences between financial conflicts and personal conflicts. That is, outcomes with financial conflicts are unidirectional because industry funds virtually all studies. They either fund them themselves or they partner with our public institutions. Those results tend to exaggerate benefits and ignore harms, or whatever. So there's this drive when things are, when financial conflicts of interest are at play, that drives scientific findings in the direction that is untrue. And there's a power imbalance. I mean, industry can afford to fund its battalions of lawyers, doctors on the payroll, KOLs, PR agents, social media actors, sock puppets, third-party salespeople. They have so much power that they can drown out independent voices. So there's a tremendous power imbalance there. But what we want to do, and here's where it's so important on panels, like if you look at panels that make guidelines or approve drugs, we want to protect the body of evidence versus judging personal bias. So if indeed the body of evidence is biased by industry influence, what we need is to get industry influence out of there, have independent people, and let their personal biases fly. If there's no argument that insulin treats diabetes, you don't need to have people who say it doesn't work. But whenever there's a conflict, and there's a genuine conflict among scientists, you need to have the people who are pro and con on those panels so that you can really argue out what the issues are and figure it out. And that's how science moves forward. So strongly held beliefs should not be used as an excuse to exclude people. Yet I documented with the FDA that every time they excluded someone for financial conflicts, they don't exclude people for financial conflicts. They have many, many people with financial conflict on the panels. Yet when they exclude people with, quote, personal or intellectual conflicts, it was always people who were concerned about the harms of a certain drug. So and it's a slippery slope, as somebody said, what's a personal bias? It's whatever you disagree with. So next slide, and then we can go to questions, I think. I think I won't have rushed everybody through. And we get, I think it's the last slide, money versus the evidence. Oh, no, and then there's the important part. Okay, so there's a tremendous power imbalance, as I've mentioned, between financial interests of power of industry and what we can put out in terms of evidence-based medicine, what gets heard, what gets replicated, what doesn't get overwhelmed by financial interests. And that has actually created, the efforts of people to improve evidence-based medicine. And there's this paradoxical effect. By improving the way evidence is produced, the process has become more expensive. And that means that these studies are even more susceptible to the influence of industry, because they have statisticians and they have all sorts of people who know how to game these studies. And so I'm not saying that it's always purposeful, many times it's just unconscious, but even the interpretation of the data, if you read a study carefully, you'll find that their own conclusions are contradicted by the very data in their own study. And that's something that was shown by Jeanne Lenzer. So for evidence-based medicine to be effective, we have to address structural issues about how research is conducted. And finally, what's a reporter to do with all this information? Clearly, I mean, I've only touched on a very tiny fraction of what goes on that can mislead us in medicine and the illusions in medicine. And I think what's important is, because of that, if you look at the last slide, what is a reporter to do? Just always be skeptical, always be skeptical, and then use a series of experts who are industry independent. They don't have a dog in the game, or what, I forget the phrase, the dog in the game, whatever it is. They don't have skin in the game, that's what it is. And there is a list of industry independent experts, and Catherine Riva and Serena Teneri are active in helping us develop that further. And I think there's going to be another list coming out. So you can access that list there and at my website and via the Lown Institute. And that concludes it. If you'll go to the last slide, that's my contact information for anybody who wants to get in touch.
All right, Jeanne, thank you so much. Thank you so much for your presentation. Can you hear me, by the way?
Yes.
It's always a bit tricky, but does it work? All right, awesome. So I think we have a small amount of time left for some questions. So please write down your questions in the chat. I'll give you some time and to think about it, you guys in the chat, and I'll come up with my first question. Jeanne, I was wondering, everything you told us, it's really complicated medical. And I can imagine if you're not trained into this field, which you are, I believe, it can be quite overwhelming, right? So
yes,
want to, well, do thorough investigation into this field, but where to start?
Yeah, so I think, yes, as has been emphasized before, you know, reading the methods is really important. It's really hard for even doctors. Our doctors fall for bad statistics all the time. So I don't expect that any of the rest of us are going to be any better. But you need to look at how people are chosen to be in a study, how they're excluded, and read the study carefully. Then go to these doctors on this list, these experts, because they can pare down what's real for you or not. And as time goes on, you'll become more and more familiar with the types of problems. The most common problems are simply things like surrogate markers. You know, ask the question, is this a clinically important effect? How long did the study last? Could we really pick up all the harms? And all-cause versus disease-specific mortality. Those are very basic things that I would say cover the majority of the problems that we see. As someone here asked about our medical guidelines are to blame for disease creep, and that's difficult to counteract, isn't it? And that's absolutely true, but the problem is who writes the guidelines? And what we see over and over is that people who have financial conflicts of interest are the ones who write the guidelines. And by financial conflicts of interest, I mean not just that they get paid as key opinion leaders or as whatever, but it also includes people whose profession relies on that particular intervention. So for example, if you ask gastroenterologists versus radiologists, what's the best way to diagnose reflux? The gastroenterologist will say, stick a tube down their throat because that's what they do. The radiologist will say, you know, do some imaging studies because that's what they do. But that's what their income is dependent on. So this complaint, well, you didn't have any experts who were cardiologists on this cardiology study. There are methodologists, and methodologists are the ones who can help understand whether a study was effectively rigged, consciously or unconsciously, or whether it was a good study that you can rely on.
All right, thank you, Jeanne. We have one more question from Jerry Vermanen. I think the last part of his also asks, what are some stories in medical journalism that will be relevant for the upcoming years?
I mean, everything's been taken over by COVID, and as soon as it's over, of course, people are going to forget it. But what we really need to get out of this time period that will be relevant going forward is concern about the next pandemic. And the next pandemic after this one, we should hopefully have tried to learn something from this one. So talk to your experts about how you can do nested case control studies, how you can learn about the kinds of problems I talked about with observational trials, so that we can help with the next pandemic. There's something else I can say about that, but I've forgotten.
All right, thank you. Anyways, I have something more to ask. I was wondering, you told us a lot about medical trickery. Did you see or notice anything on about COVID, like stories in which or reports in which journalists have been tricked? Actually, they just did bad reporting because it's just so hard to oversee the whole field or see the details. Do you have examples?
It is. Sure, the hydroxychloroquine thing was one example where reporters were reporting this as a breakthrough initially. I think the other thing, to expand on the COVID, what will be important going forward is not just how do we know which measures make a difference during a pandemic, but what are the root causes? Because factory farming is a huge issue. I mean, if you want to talk about the wet grocers in China as being petri dishes for combinations of viruses and germs, that's true in factory farms, where you have animals piled on top of each other, pooping on each other's heads, weakened immune systems. And there's a lot in that area to look at. And I think the other area is biological niches. There was virtually no flu during the early COVID pandemic. It's sort of interesting. If one virus or germ occupies a certain spot, does another virus or germ go away? Sometimes there are multiple germs at once causing a problem, but sometimes a biological niche is established. So I think that's going to be an area people will be looking at somewhat. And I can expand a little bit on the biological niche. So say, for example, a woman takes an antibiotic and gets a yeast infection. You've killed off some bacteria, so the yeast overgrow. And this is what we're talking about with a niche.
All right, thank you. People, this is your last.
Are most of the people listening already experienced as medical journalists, or are they people largely entering into the field because of COVID?
Well, guys, do you consider yourself an expert in the field? Let's just ask. Let's see.
Or experienced, not expert. I wouldn't count myself as expert. So just.
Oh, well, in that case, we have just.
That's what no expert.
Group is from all areas,
okay.
who are joining us. No, we said no, not at all.
Well, we do really urge you, the 90. Okay. The 90% issue is to get to that list of industry independent experts, to use the resources mentioned that I put on that last slide with GIJN and Recheck and their wonderful book, and to go to Health News Review and look at their toolkit. But most of all, you need to turn to experts who are familiar with these issues and deal with the very things I was talking about.
Yes, and of course, just don't be afraid and dive straight in, right?
Yes, absolutely. And don't be deterred if someone gets nasty with you, because there are experts who will get very nasty if you press questions about harms of their intervention that they're promoting, or they get nasty about financial conflicts. And if you, I've had doctors just lie to my face about whether they had financial. I'll never forget one doctor who I reported in the British Medical Journal that he had, well, now BMJ, that he had financial conflicts, and he was a principal investigator on a clinical trial. And when I confronted him with this, that he told me no, he had no interest. He said, "Oh, I didn't know that I was named a principal investigator." And he was a principal investigator announced in the JAMA report on the study. So don't be shy.
All right. Exactly. I think we're running out of time, so we need to round off. I'll leave you guys with the slide. Guys, don't forget that this session is recorded, so if you need to or want to just take your time. It's just too much, just you can take your time and watch it all over again. Jeanne, I really want. Great. Thank you so much that you took your time all the way from the States. And well, I hope we stay in touch.
Thank you very much for having me. Thank you very, very much. Bye.
All right. Goodbye. Bye, guys.